Sepsis, another disease entity one way. One, it's cause of death, and it is mainly immune mediated mechanism driven by. About sepsis, it is around the world from dawn of time, having been described for more than 200, 2000 years. Clinical definition is driven by recent time with the development of Western science. Sepsis occur in approximately 2% of all hospitalization in developed countries. Mind you, about underdeveloped or developing countries, data scare. Sepsis may occur in between 6 to 30% of all ICU. In general, more than 50% of severe sepsis patients will require ICU admissions. Fatality rates, sepsis 10 to 20. Severe sepsis nowadays merge, and we'll say sepsis 650, septic shock 40 to 80% like. This is in combination, 10 to 50. What is sepsis? Presence of pathogenic organisms or their toxins in the blood and tissues, or the poison condition resulting from the presence of pathogens or their toxin as in septicemia. Other way, presence of pathogenic organisms or their toxins or byproducts in the blood and tissues, or in the poisonous condition resulting from the presence of pathogens or their toxins as in septicemia. Bacteremia may lead to sepsis. Septicemia is toxins in the blood, the toxemic state. Sepsis, it's a life-threatening or life-threatening organ dysfunction caused by a dysregulated host immune response to infection. That is the sepsis. For clinical operationalization, organal dysfunction can be represented by an increase in the Q, SOPA score 2 points or more. Sequential organ functional assessment, SOPA score. It's a clinical score. Septic shock, subset of sepsis in which particularly profound circulatory, cellular, and metabolic anomalies leads to shock. Collapse, associated with a greater risk of mortality than with sepsis alone, septic shock. Septic shock, sepsis plus one of the following conditions. Mean arterial pressure less than 60 mm per mercury. In a previous hypertension patient, it is less than 80. After adequate fluid resuscitation, that's the main important thing. Because in here we don't know, shock there are hypolimic shock, proceeding with dehydration, septic shock, likewise the hypothermic shock. Likewise, there are different kind of hyperthermic shock. Likewise, there are different type of shocks are there. To differentiate from common one is hypolimic shock. If we give fluid bolus, if it is not responding with the adequate fluid resuscitation, we think is it septic shock. So it further it needs for pressures to maintain blood pressure after fluid resuscitation. That's the other important point. And adequate fluid resuscitation is 40 to 60 milliliter per kg saline solution. Often lactate is more than 4 millimoles per liter. Those two, mean arterial pressure less than 60, required pressures to maintain BP after adequate fluid resuscitation, and lactate level more than 4. Pathogenesis, it's the most important thing. You know, innate immunity, major role. Bacterial peptides, complements, mannose binding lectin, and neutrophils. Antibacterial peptides, they act in first line defense. But with the activity, there is pathogen associated molecular patterns with lipid A in gram negatives, like T-cholic acid and prostaglandins. Sorry, peptidoglycans in gram positive cell walls. Peptidoglycans and lipo-T-cholic acid in gram positives. Pattern recognition receptors in host. There are T cell receptors, C arms. Likewise, there are other nucleic proteins They term inflammations. And there is another one term is DAM, damage associated molecular pattern. With the presence of cellular damage by activity of innate and adaptive immune response, again invading pathogens, or damage by itself or body cells. They produce S100 B1 extracellular DNA, RNA, and histones. Those are endogenous, and those terms alamines. So inflammations, alamines, PAMs, and DAMs, they are the triggering factors. So initial phase of sepsis, it's an overactivation of the immune system take place in an effort to eliminate the invading pathogen. It's the initial stage. It leads to cytokine storm with the presence of these PAMs and DAMs and associated with pattern recognition receptors. So they lead to overproduction of pro-inflammatory cytokines like TNF alpha, interleukin 1, and interleukin 6. Then, if it's going as irreversible manner. So there is rapid overwhelming or other way cytokine storm is there. So once it goes for the shock, it differ. It's ultimately it's a micro and macrovascular collapse. So the pathogens of sepsis is almost complex. Involves a dynamic interplay of pathogen and the host. So there are genetic vulnerability also explained. So sepsis, as I said, it's divided into two phases. In the initial phase, what I described earlier. So in the initial phase, it goes and develops into overactivation of the immune system. So here you can see some extracellular ligand recognition in bacterial sepsis, toll-like receptor 4, 1, 2. So bacterial ligands like lipopolysaccharide, truncated lipopeptides, likewise there. So with the presence of T cell receptor 2 and 4, release of interleukin 1, 6, and alpha, so they leads to endogenous pyrogens, upregulate the synthesis of secondary mediators, other pro-inflammatory cytokines, macrophages and mesenchymal cells such as fibroblasts, epithelial and endothelial cells. Stimulate the production of acute phase proteins, so attract inflammatory cells. So classical acute phase C-reactive proteins, it's a classical one. There are complement components, C3, C4, coagulation proteins, fibrinogen, fibronectin, plasminogens, transport proteins like haptoglobulin, ferritin, ceruloplasmin, proteases, kallikrein, likewise protease inhibitors, there are a lot. Complement plasma, anabolitoxins, C3A, C5A, and survival rate of patient is highly negatively correlated. When in this case, there is a strong and activation of complement also there. When T cells, specifically Th1, Th2 cells, play an important role in regulation of the inflammation. Th1 help one cell-mediated immune response characterized by the production of interferon gamma and interleukin 2 into the Th cell-mediated immune response. It is characterized by the production of interleukin 4, 5, 10, IL-30, leading to further immune suppression. Now it's got to second stage. In addition, lymphocytes and dendritic cells also leads to immune suppression. Also, it triggers, now with the immune cytokine is strong, leads to apoptosis of macrophages and neutrophils also there. IL-17 is a regulator cytokine, triggering number of other cytokines, IL-1 beta, IL-6 and TNF-alpha, connecting with lymphocyte and macrophage. Neutralization of IL-17A can significantly improve the survival rate of patients with sepsis. So IL-17 in sepsis, it's not good. So with the presence of IL-17 antagonist, anti-IL-17, which it's a neutralization and survival of sepsis is high in those patients. Once in the initial hyperinflammatory patient progress, it slows for prolonged or intensive hypoinflammatory state. Initially hyper, now in it, for 5 days it depends. It goes for this vicious cycle continuous. It's irreversible when it comes into shock. Now it goes for hypoinflammatory state. So in this case, there is immunosuppression. So secondary infections such as ventilator-associated pneumonia or bloodstream infections, specifically with the low virulent pathogens such as Acinetobacter, Pseudomonas, Enterococcus, and Candida species are now emerging there. Most are, some may be found in our body normal flora. Some are from this hospital flora. So they colonize there. Once immunity is depleted, they are now become pathogens. So secondary infection results in repeated cycles of hyper and hypoinflammatory phase, further complicating the sepsis process. It's going on like that. Because secondary infection leads to hyperinfection plaques, but patient can't mount immune response. So further it deteriorates. So there are some anti-inflammatory cytokines there for the idea. So this is immune activation. It's a pro-inflammatory response. Later on, it goes for anti-inflammatory response here. So now it's a time for development of nosocomial infection. In initial stage, apoptosis of lymphocytes and antigen presenting cells. That's how it goes for immunosuppression. Hyperinflammation, hypo, recovery, or death. So you have to know about the pathogenesis of sepsis. Then how we detect the sepsis. Initial clinical presentation in acute presentation, patient comes in, patient knows very well, and within this hour or within this short time frame, patient knows unresponsive. So prior to that, if patient comes, maybe coming with the diarrhea, maybe fever, maybe any other symptom, but we have to do the basic clinical examination, checking the blood pressure, respiratory rate, pulse rate, likewise. Then with the history, we have to get the idea, is this patient in sepsis, septic patient. Meanwhile, we do blood cultures too, and we do markers of inflammation, that's C-reactive protein. It's a mind, it's an acute phase reactor, and procalcitonin. Nowadays, it's bacterial sepsis, it indicates. Compared to CRP, PCT is higher in detection of sepsis, specifically bacterial sepsis. So you can see this receiver observer characteristic curve, sensitivity and specificity. You can see procalcitonin, if it is lies more towards sensitivity axis, then that particular test is much more quality and useful nature is high. Compared here CRP, it goes some distance compared to PCT. This axis. Here in sensitivity, 900%, sorry, around 90 to 100, PCT is still high about for the detection of bacterial sepsis. So PCT is advised. Another important thing is markers of inflammation. If we think about CRP, secretion start within 4 to 6 hours after stimulation, peaking after 36 hours. So it is easy to perform, easy to determine, but low cost. Often nowadays automated tests are there, but we have to do every other day, 48 hours. But if it is about this procalcitonin, even it within 4 hours start stimulation and peaks at 8 hours clearing when the insult is under control. So we can do daily. That's one important thing. PCT is available in samples. Assay is relatively easy to perform nowadays, but cost moderate. Results available within 2 hours. So it's very much important. Once established it is sepsis, as medical officers, our duty is to prevent the patient goes for sepsis. It is reversible. If it is go for sepsis shock, it is irreversible. So we have to prevent going into irreversible stage. For that, we have to do what? We have to start antimicrobials, appropriate antimicrobials. Prior to that, we have to take blood cultures and markers of inflammation. Meanwhile, we have to find the focus of infection. Is it? Now we are going to give the empirical antibiotics. We don't know the focus. We have taken blood for culture. If it is there's pneumonia, I mean features of respiratory infection, you can take. If patient is comfortable, you take sputum or nasopharyngeal aspirate. If it is patient is with urinary tract infection, we can take urine prior to start initiation of antibiotic. But time is critical. Time critical. We have to do as soon as possible. We have to detect the condition as soon as possible, and we have to treat the condition with appropriate antimicrobials, empiric. We give broad spectrum antibiotics, and we can find the focus, and we have to find out the pathogen. Then we can target the antimicrobial in 70 to 48 hours likewise. So we do CRP, we do second CRP sequentially in 48 hours. PCT do today, then with that we can do tomorrow, and we can monitor the response as CRP also helpful, but PCT is daily, so it's rapid. But if patient go for shock, no, prior to all the therapeutic role, we have to go for intramuscular adrenaline. It is epinephrine, given in IEM. Usually given to anterolateral aspect of the middle thigh of the middle third of the thigh. Safe, easy, and effective. Adult dose is 0.5 milligram IEM, that is 500 micrograms, or 0.5 milliliter of 1 into 1000 adrenaline. Child IM dose, equal volume of 1 into 1000 adrenaline is shown in bracket. That is more than 12 years, we give usual dose. Otherwise, 300 micrograms if the child is small or prepubertal. More than 6 to 12 years, it is 300 micrograms IM. Less than 6 years, 150 micrograms we give. Other thing is we can repeat after 5 minutes if there is no clinical improvement, 2 or 3 times. Same time, we have to optimize the care. As I said earlier, antibiotics, broad spectrum, source control, we have to identify if abscess is there. We have to drain it once the patient is stabilized. At the same time, we can give fluid therapy, steroids. At the same time, oxygen if it required, and other vasopressure. Pressures, it depends. And there are still, if patient goes for septic shock, it's irreversible. No therapeutic options available, frankly, because it's in a terrible condition. So there are postulated treatment modalities, but our duty is prevent going into septic shock, because there are corticosteroids, but it's not. There are hemophil filtration methods are there, filtering all the blood products. But in that case, patient is set in a cytokine storm. So friendly cytokine as well as toxic cytokine both filter out, and it's a mess. So there is no such cure. So likewise, there are, I said earlier, interleukin 17A and anti-neutralizing antibody. They are raw but unclear. Likewise, and role of granulocyte monocyte colony-stimulating factor also. Improved clinical parameters but not survival. So that's there. So take home message is recognize the sepsis early and determine the severity. Early antibiotic critical, resuscitate, early goal, directed therapy is the very much important.